Welcome to the ASCO Guidelines episode of the ASCO University Weekly Podcast. My name is Davendra Sohal and I am an assistant professor in Hematology and Medical Oncology at the Cleveland Clinic. Today, we feature the ASCO Clinical Practice Guideline on metastatic pancreatic cancer. This guideline was the result of a several months long process where the panel decided on 6 key questions and collated all data from the literature relevant to these questions and created consensus evidence-based guidelines. Subjective opinions have been minimized, and for each recommendation, a formal ranking method was used to assign level of evidence and strength of recommendation. Clinical question 1 is on the workup after a tissue diagnosis of pancreatic adenocarcinoma. The recommendation is to obtain a CT scan of the chest, abdomen, and pelvis to assess extent of disease. MRIs are more cumbersome, expensive, and difficult to interpret, and PET scans are not standards of care and provide less anatomic clarity. Therefore, these studies are not recommended. Then, a careful assessment of the patient's performance status, symptom burden, and comorbidity profile is recommended. This will allow determination of risks of cancer therapy. Next is a goals of care discussion with patient and key caregivers. There are no wrong choices for therapy as long as there is clarity on goals of care and mutual consensus. A multidisciplinary review of each case should be considered. The final recommendation is that every patient should be offered available clinical studies. These could be interventional studies of cancer or non-cancer drugs, observational studies such as quality of life surveys, biomarker studies, etc. Clinical question 2 is on the appropriate first-line treatment. There are multiple options now, and the panel developed some specific criteria for use of each option. FOLFIRINOX, which is 5-fluorouracil, irinotecan, and oxaliplatin, should be used for patients who have an ECOG-PS of 0 or 1, a favorable comorbidity profile, and patient preference for aggressive therapy. For patients who are perhaps a step lower in the overall performance status assessment, gemcitabine and nab-paclitaxel are recommended. For patients with an ECOG-PS of 2 or a limiting comorbidity profile, single-agent gemcitabine is recommended. For patients with an ECOG-PS of 3 or greater or a severely limiting comorbidity profile, the panel did not make a case for recommending chemotherapy. In this context, comorbidity profile is defined loosely based on bone marrow, hepatic, and renal functions and comorbidities requiring or not requiring ongoing medical care. Clinical question 3 is on the appropriate second-line treatment. The use of gemcitabine and nab-paclitaxel is recommended for patients who received FOLFIRINOX as first-line therapy and still maintain a relatively preserved comorbidity profile. A 5-fluorouracil doublet containing oxaliplatin, irinotecan, or nanoliposomal irinotecan can be used in patients who received gemcitabine and nab-paclitaxel as first-line treatment. For patients with an ECOG-PS of 2 or a limiting comorbidity profile, single-agent gemcitabine or 5-FU is recommended. There are no data to support any third-line therapy. As always, clinical studies should be considered strongly. Clinical question 4 is on the appropriate time to introduce palliative care, and clinical question 5 is on the recommended strategies for control of pain and other symptoms. The panel felt strongly that palliative care is an important adjunct to cancer-directed therapy and should be introduced as early as possible in the course of treatment. Aggressive symptom control is required to minimize symptom burden and to contribute to more durability of chemotherapy regimens. Clinical question 6 is on the recommended frequency of follow-up. The recommendation is to evaluate response to therapy with imaging, preferably CT scans, after 2 to 3 months of therapy. Following that, clinical assessment is appropriate. Routine use of PET scans and tumor markers such as CA19-9 is not recommended to assess response to therapy. The second point is that duration of therapy is not definite. An ongoing discussion on goals of care should guide any treatment modifications or breaks. Thank you for listening to this episode of the ASCO University Weekly Podcast. For more information, be sure to check out ASCO University's quarterly e-learning series on ASCO Guidelines coming in 2017 by visiting university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.